talking to you this afternoon about this topic. Following in from a good talk on PSPIs, my focus is going to be predominantly around the causes of death in children, but I'm also going to talk about the neonatal population and very briefly on stillbirths as well. So the outline of the talk is I'm going to start by presenting some of the findings from the CHEM study, and I'll explain what the CHEM study is. And then I'm going to very briefly talk to you about MITS, which is minimally invasive tissue sampling as a standard of care practice. And it's something that seems to have died away in the pediatric community. And then we're going to have a small game at the end where our panelists from Stellenbosch and from Durban are going to see if they can determine the cause of death in a few cases and looking at what are the modifiable factors to prevent those deaths. So by introduction, CHEMS is a project, and I'm presenting this on behalf of the CHEMS network. And the reason CHEMS was created a few years ago was because of this question is, are the estimates of death or the causes of death, are they accurate? And we've all seen this pie before, and these pies keep being published about what is the distribution in terms of the causes of death in under fives. But often the underlying cause is the only cause that's reported in these pies. And we know that death can be caused by more than one cause in the pathway. Often we find that these causes are attributed to verbal autopsy because a lot of these deaths are happening outside the hospital environment. And we know that in LMICs, diagnostic tests are not widely available. So often you don't get the granularity that you require to ascertain the cause of death. And if these causes of death are infectious, then we know that often these are polymicrobial in nature. So CHEMS, which is the Child Health and Mortality Prevention Surveillance Program, is a program that's funded by the Gates Foundation through the Emory University and multiple partners. It has 7 countries, and South Africa is one of the countries, and I've listed all the other countries there. In addition to the 7 countries highlighted in green, there are 2 new countries that have come on board that are highlighted in blue, taking it to 9 countries doing surveillance. So really what CHEMS is trying to do, it's trying to engage with communities to identify and examine the deaths that occur and provide the feedback that is required to these families as to what are the causes of death, as well as provide a public health requirement. And how it goes about doing this essentially is by using clinical records, verbal autopsies, and this concept called minimally invasive tissue sampling. Now, what minimally invasive tissue sampling is essentially is where samples are taken from multiple organs in a child who's passed on. And these are taken without the child being cut as a full postmortem would be. So blood specimens, CSF, swabs, stool, and then histology samples of liver, lung, heart, brain, and bone marrow, and placentas for those stillbirths and early neonatal deaths. Once these samples are taken, and the whole host of samples are then subjected to testing. And amongst the testing is culture, testing for HIV, TB, malaria, and then a whole lot of molecular testing that's performed in an array of specimens, and then histopathology for some of these specimens as well. So just to re-emphasize, essentially the baby is, once the baby demises, you don't cut the body, but you use a series of needles and biopsy needles to puncture different parts of the body so that you can ascertain these samples. Now, once the samples are taken, so then you have the clinical information, you have the verbal autopsy, the clinical notes, the maternal notes, you have a whole array of all these samples with their results. It then goes to what we call a determination of cause of death panel. So it's a group of individuals that sit together, and these individuals ranging from clinicians to microbiologists to pathologists, obstetricians, as well as pediatricians and neonatologists, all trying to determine what is the cause of death and what are the modifiable factors around that death. But there is some limitations, obviously. And as I've described this procedure, you can imagine that we can't really give you an idea, or this procedure can't give you an idea about congenital heart defects or major organ defects, because the way the samples are taken, you're not actually visualizing any of these organs. Secondly, chromosomal abnormalities, unless they tested for with genetic testing, are often not available. And if there's poisoning, then toxicology is something that's not readily available. And the CHEMS program is looking into how it can identify these as causes of death as well. So once this decode panel meets, they sit down, and essentially the point of the meeting is to use the WHO format of ascertaining cause of death. And just to blow this up, a bit more is that it's broken up into part 1 and part 2. And in this part 1, you need to describe the underlying cause of death. So what injury initiated the events? Is there anything what they could call morbid causes or anything in the pathway leading up to your immediate cause of death, which is the direct preceding cause that led to death? There's also a part 2, which you would call a other significant contributor or other conditions that contribute to death, but were not necessarily in that pathway leading up to that final cause of death. So we often refer to this as the causal chain and not in the causal chain. But it can get complicated, and just humor me for a few seconds. The first thing that for me gets complicated is it the chicken or the egg kind of scenario? So I'll give you an example of this. Let's say you had a child who had group B strep infection and was born prematurely. The question then comes to mind is, did the GBS in the mother, which resulted in utero infection, result in the preterm birth? So is that the one scenario that's happened? So did GBS come before preterm birth? Or is it the other scenario? And we know that preterm babies are at increased risk of GBS infection. So is it the baby that was coming out preterm and then had an increased risk of GBS infection? So sometimes you do struggle in determining where in the pathway to death things follow. Other times you find that the pathway is not linear. So it's not one thing that led to another thing that led to another thing. And an example of this is a child who's got severe malnutrition, malaria, and pneumonia. So I struggled with this one because I know that severe malnutrition is going to increase the risk of pneumonia. So if that was underlying and the immediate cause was pneumonia, but then how did malaria fit into this whole thing? Do children with severe malnutrition have an increased risk of malaria? And that's not really the case because the mosquito will bite you whether you have severe malnutrition or not. So it gets complicated, and that's why today we have these lovely panelists that are going to come on board, and we're going to give them some cases to work out. This is a paper that was published at the end of last year, and really what this paper shows is that when you look at the causes of death in terms of underlying causes, comorbid causes, and immediate causes of death, you see that you can start at one sort of area from an LRTI, and you can end off in another area where sepsis is your likely immediate cause of death. So it really, you don't have to read the detail of this, but it's really trying to highlight that there's a whole lot of pathways that can occur to that endpoint of death. So I'm just going to briefly tell you some of the results of CHEMS. So the first thing I need to tell you is that CHEMS has enrolled about 11,000 participants over this last few years, and of these, MITS was completed on 6,900, and now it's past the 7,000 mark, which means that in all these countries, we've done this assessment on over 7,000 babies, and we've already decoded in terms of what cause of death is in almost 6,000. Now, why this is important is because it's a huge, huge data set of information. And what we're finding is that when we look at under 5's deaths, and if we include stillbirths in the pie, a third of that pie is stillbirths, a third of that pie is roughly neonates, and slightly less than a third of that pie is children. So you can see in terms of contributing to deaths, a large chunk of children are dying either before they're born or dying in the first month of life. So let's look at stillbirths very quickly. When the panel looked at stillbirths, what they found is that 73% of stillbirths, the cause of death was related to some sort of hypoxic event, whereas in 9% it was some infection cause and 7% was a congenital cause. And most of the stillbirths only had one cause of death. So the problem, though, is that when someone looks at the diagnosis of perinatal asphyxia hypoxia, it doesn't tell you anything. It doesn't tell you what exactly happened. Was it an antenatal event? Was it an intrapartum event that occurred? And really, this needs to be teased out further. When we look at neonates as causes of death, you see that a third of these are related to preterm complications, and you've heard about that in the earlier talk. Almost another third is related to asphyxia or hypoxia-related complications. So what this is trying to show you is the contribution of these causes, and I'm only reflecting the underlying causes to death. And in neonates, a large proportion of them have one cause in the pathway to death. Now, if you just take the stillbirths and the neonates in terms of their sepsis, and you look at the etiology in terms of organism, the two big culprits that are coming up consistently, and South Africa is no exception to this, is Klebs and A. Baumani, especially when we look at infection occurring after 72 hours. And this is mostly hospital-acquired infection. So when we look at stillbirths and neonatal deaths together, and we say, what are the likely factors or understanding what are the likely factors that underlie this, maternal conditions seems to be striking. When it comes to placental and cord complications, maternal hypertension, labor-related complications. And if you treat these in isolation, and unfortunately, we're not going to get to the problem, and really talks to this collaboration that needs to occur between the obstetricians and the neonatologist. Now, let me draw your attention to infants and children. So I'm really talking about those from 1 month to 59 months of age. And here you can see the spread is much more vast, going right down from HIV-related causes, lower respiratory tract infection, malnutrition, congenital defects. So the spread is big, but let's tease this out a bit more. Before I do that, just to say that most children also have more than one cause of death in the pathway. So this is a paper that just came out also at the end of last year. And really what it's trying to show you is that if you look at what the immediate cause of death compared to the underlying cause of death, what are the common sort of causes? And what I want to point out to you is this. If you look at the underlying causes of death, malnutrition, let's ignore malaria for South Africa, and HIV are two big underlying issues when it comes to what leads to the past. So this is really the precursors of the events to death, is malnutrition and HIV for a large chunk of the patients. And then when we look at what finally kills them is lower respiratory tract infections or sepsis. So you're having this group of children where they're coming with this underlying comorbidity, and then they're succumbing to LRTIs or to sepsis. And if you look by organism, I just want to show you that Klebsiella pneumonia, Streptococcus pneumonia, when we look at appearing anytime, whether it's underlying or immediate, these pathogens seem to predominate. Almost 30% of the cases are Klebsiella pneumonia infection, and pneumococcus still 20%, despite having the pneumococcal vaccine. Causes like Haemophilus influenza are things that we thought were big culprits as well, contributing to death, come at a lower proportion compared to those. Now, if I draw your attention in the same age group, but just talking about pneumonia, and basically we find that almost half of the children have some sort of pneumonia or LRTI in that process of death. And I just want to pick out on the organisms. Again, Klebsiella, big culprit, strep pneumo, big culprit, and CMV, from a virus point of view, another big culprit. But don't forget the fact that cis RSV, and as we're going into RSV season, 6.4% of all the pneumonia deaths were due to RSV. Importantly, again, when we looked at the median number of attributable etiologies, meaning organisms, the median number was 2, which means that you're likely to have more than one organism coming up, again, talking to that point of polymicrobial infection. And I think more and more we're realizing this as a reality. Not really common in South Africa, but some of the sites showed that only half of the children got onto oxygen, and you can see that can be a really modifiable factor. But when we look at the underlying cause of these pneumonias, malnutrition seems to come up again. And I just want to show you this. This is the publication of that same pneumonia paper. And if you look again, malnutrition and HIV seem to be, and what I'm showing here is deaths occurring in the first 72 hours to admission, so not hospital acquired. And if you're looking at the underlying cause circled in this diagram, malnutrition and HIV stand out. Now, just if we look at just South Africa and we break down what malnutrition may look like, just underweight or severe underweight, 44% of all our deaths in South Africa that occurred at this site in Soweto were underweight for age, or severely underweight. Severe stunting in a third, and more concerning, and that is the most concerning, is the severe wasting in a third, which is telling you that the severe acute malnutrition in a third of patients that died in the South African site. And when we talk about vaccine preventable diseases, and the point I've highlighted is that pneumococcal disease is still causing death, even though we know that there is a vaccine. And it may be, and I accept that there may be those serotypes that are not in the vaccine, but it is concerning that pneumococcus still plagues us. And hopefully looking to the future with the RSV and the Group B strep vaccine, hopefully those will also come down. So what are some of the learnings from CHEMS? If we look at stillbirths and neonatal deaths, I think we need to say that hypoxia or asphyxia is a problem, and therefore we have to turn to the pregnancy and the delivery. In terms of the neonate, we need to talk about infection control and the prevention of preterm birth, and we need a strategy for antimicrobial resistant pathogens. And for the older children, those from infancy up to less than 5, HIV still remains a problem. Malnutrition is common. And when we look at modifiable factors, this is a paper that came out at the beginning of this year. It shows that there's a ton of modifiable factors, from health-seeking behavior to reaching a facility to receiving the correct care at the facility. So important things to highlight, for example, is the caregiver right on the top, the caregiver taking a long time to seek care, caregivers being turned away from facilities or transport issues, and then problems with prescriptions. And I think South Africa is maybe not too much of a problem there, but facility availability problems, accessing diagnostic tests, caregivers do not provide the appropriate treatment. So these are delays that can occur in the health-seeking behavior. Now, lastly, just to tell you that CHEMS, the benefit of CHEMS is really to make the difference in the communities, where you take the data learned from CHEMS and then you put it into action. These are some of the sites showing in the top figure. This is Sierra Leone engaging with government. This is, I think, Kenya, if I'm not mistaken. This was the food program, and these are some of the education programs happening in these countries. But one of the standout sort of discussions is when we looked at the data around neural tube defects from CHEMS, we found that Ethiopia was really an outlier. And the reason for that is it was recognized that fortification with folate was a necessary requirement. And now Ethiopia fortifies their salt with folate to reduce the risk of neural tube defects. So finally, to say, acknowledging the CHEMS communities, families, people who have agreed, and I must say it's amazing that families have agreed, even though they've been in the very emotive point of having lost a loved one, agreeing to allow these processes to happen so that it can better other communities, other children. So really acknowledgement goes out to the families that have contributed to this and the communities. And also just to point out, this is some of the members of our team who actually go out and deal with this very emotional component day in and day out to go and find the death, counsel the family, and then do the procedure on these deaths. So the second part of my talk, and I'm really coming to the end of the talk now, and then we can go into the game, is the yellow part, which is MITS as standard of care. So the American Academy of Pediatrics, this document is publication has just come out this week. And basically what they're saying is that there needs to be a case fatality review. And they're saying that every child's death should be investigated, especially those that have come unexpected. So I think that's the first point, is that we can't just rely on the clinical information and the ante-mortem diagnosis, especially when it's unclear. The second thing they're saying is that there needs to be consistent reporting of the death certification, and that's an important component of today's talk. And the last thing they're saying is that we should be encouraged to provide sensitive feedback to primary care providers. And I think this is an important one. So if we're finding that there are obstacles to care occurring from the primary level, that's where we as pediatricians need to step in and say, can we tactfully and sensitively provide that feedback? And it may just be that these are systemic issues that people need help to overcome. So this is a paper we just published last month in the SAMJ, and what this paper says is that should post-mortem minimally invasive tissue sampling be implemented again as standard of care? And I'm saying again, because I remember as a registrar, the minute there was a death, we had to go to the death and take some samples. What we usually would be expected to do is we're expected to do a lung puncture and a liver puncture and send that for histology as well as for microbiology. I remember times going to the mortuary after the post-intake ward round to go do these procedures, and it seems to have fallen away. And the important information that we derived from these limited tissue sampling can provide more granular information around the cause of death. So this paper, if you have some time, read about it. It talks about the acceptability amongst health professionals. So health professionals are very much accepting this process. There is a public benefit to it. And then we've provided a pragmatic approach, noting that South Africa has limited resources. We've provided a series of flow diagrams that allow you to limit the investigations required. And I'm just going to use the first one as an example. If you had a stillbirth, our recommendation is visualize the body. If you notice obvious congenital abnormalities, you don't really need to do anything else. If the verbal autopsy is in keeping with preeclampsia, premature rupture of membranes, and that's helpful. And if you have the maternal file, most of the cases go down around two pathways. Is it a hypoxic event or is it an infection event? And just by collecting the placenta, just by placenta histology, you can unravel most of these issues. Very quickly, these are the neonate algorithm, and it really separates it by the premature versus the term infant. I know it looks busy, but when you get to it, you realize it's actually just telling you which test to do. And this is the infographic for the child, which basically separates them into a previously well child with no comorbidities, a child with SEM and HIV, or in the case of a DOA, what do you do? So that takes me, Marty, then to the last part, and this is the game time that we promised everyone. And we've got Team Stellenbosch by the winelands, and we've got Team Durban by the sea. And what I'm really going to ask the teams to do is, number one, I'm going to talk to a case series, and I'm going to ask the two teams to decide what they would put in the pathway to death. So what I would want the teams to do is say what the underlying cause of death, what the immediate cause of death, so right at the top, and is there anything else in the causal chain towards the death? And if it is infectious in nature, then I would like to ask them to please list the pathogens of interest for that. And then what Marty's got set up for you is, if once the team has provided their answer, you can vote and say which team you would vote for. Is the Stellenbosch team getting this right, or is the Durban team getting this right? It would be real bummer if they both have exactly the same things, because then we got no one to vote for. And lastly, what would be their modifiable factors that they could have identified to prevent the death? So Marty, I'm going to stop and hand over to you if you want to say anything else about the game.
No, thank you, Ziyaad. I think you've got that game right. I do wonder if we can just ask the two teams whether they don't mind maybe just having a piece of paper and writing that down. And then are we going to ask you to just read. So don't steal the other team's results, what they are saying. So maybe you should actually write it in the chats so that everyone can see what your cause of death is once Ziyaad has given you the case. Okay, so please write it in the chats. Great. So Ziyaad, I think you can go ahead. I'll share the poll once they have answered. Okay,
fantastic. So again, Team Stellenbosch, thank you for agreeing to this. Team Durban, thank you for agreeing to this. This is not meant to be a exercise where we look for, whether you're right or wrong. That's not the point of this exercise. The point of this exercise is just the fun and the engagement of the game. So like Marty's saying, what you're going to put in the chat is you're going to say what you think the underlying cause of death is, what the immediate cause of death is, and whether there's anything else in the pathway. So if there's anything else in the pathway, the way I suggest you do it is say underlying, say in the pathway, and list them in their sort of hierarchical order, and then put the right on the top, the immediate cause of death. If any of those are infectious in nature, please list the organisms of interest. And I think keep thinking of, you can use ICD-10 or ICD-11, what the diagnosis is. I think you need to have a diagnosis as the cause of death. So let's go to the first case. So I'm going to read, and I'm going to just nitpick on a certain things, but not read everything in detail. So if there's something you're missing, just please say go back. So this is a neonate. The baby is 5 days old. The baby was born in 2022 and demised on the 16th. So baby only survived for 5 days. The gestational age was 26 weeks, and the baby was born at 1,005 grams. The mother was 24 years old, G3P2. She was RPR negative, RH positive, HIV positive. She had a previous Caesar in February 2022. So earlier that year for PIH and fetal distress. And she received 1 dose of steroids. At that delivery, she had, or at this delivery, she had a CD4 count of 700 and the HP was 9. She was referred to hospital just a day before the baby was born because of hypertension. Her blood pressure was 201/150, so she had pregnancy-induced hypertension. She delivered a baby by cesarean section for fetal distress. ABGAs were 5 and 7. The baby was put on a neopuff, started crying within a minute. Noted to have RDS and then placed on CPAP. The birth PCR was negative, and then over the course of the next few days, the baby started weaning off the CPAP. White cell count, HP, and platelets are there from your day 1 bloods, and your blood culture came back negative after a few days. And day 2 blood CRP was less than 1, and you can see the rest of the UNE. On 2-3 days later, they noticed the baby was jaundiced, and obviously the baby was put under phototherapy. But on the 15th, the day before the baby died, the baby was noted to have abdominal distension, later noted to have vomiting, desaturating, and cyanosed. There was decreased bowel sounds, and the gas done, the pH was 6.9 with a metabolic acidosis. The baby was assessed as having septic shock, and blood pressure at that time was noted to be very low. The thought was also that the baby has NEC. Bloods done there showed a CRP up to 86, a white cell count of 1, platelets of 48, and the blood culture 2 days later came back as an A-Baumani XDR. The baby was a difficult intubation, pulmonary hemorrhage, inotropic support, went to ICU, X-ray looked like a NEC2B, echo showed PPHN, and later the baby demised. The MITS was done after 21 hours of the death, and in the MITS, they basically found the weight was 1 kilogram and a distended abdomen with some bruising on the right arm. So post-mortem testing was done. The blood culture grew a Klebsiella pneumonia, Serratia, A. baumannii, and strep species. The CSF grew a moderate growth of A. baumannii and CNS. Malaria was negative, HIV was negative. Both lungs grew A. baumannii, and one lung grew a Klebsiella. On the tech results, in bracket is the CT value. The Kleb pneumonia came back at 24. In the blood, in the CSF, we got Kleb's pneumonia. In the lung, we got Kleb's pneumonia at 29, with A. baumannii at 24. In the rectum, we've got adenovirus and aromas species, and the COVID was negative. The specimen was then sent to the NHLS for histology. The liver said mild sinusoidal inflammation and congestion, but they found leukocytosis in the sinusoids, and that's usually a sign of infection. The right lung and the left lung, they saw some fetal lung with expanded air spaces. The CDC also looked at the liver and the lung, and the CDC said that the lung had non-specific findings, but when they did immunohistochemistry, they found Klebsiella pneumonia in both the liver and the lung. So I'm going to show you what that looks like. So this is the immunohistochemistry, and you can see them picking up the Klebsiella on this specimen. So just going back to the previous slide again, the mother gives a narrative. She says, I'm just going to summarize. She says, I'm from Mozambique. I came to South Africa in October. I was pregnant. On the 10th of November, I felt pain in my stomach. I went to the clinic. They checked and said I was HIV positive. They took me to theater. The baby came out, and they said the baby had a breathing problem. They put the baby on oxygen. They inserted a feeding tube. On the 14th, the baby was out of oxygen. On the 15th, he was put the baby on lights, and they blindfolded them. On the 16th, around the 16th, they told me the baby had passed away. So I'm going to now turn to our two teams and leave it to you, Marty, to tell me what's going on, because I can't see.
Okay, great. So I don't know if the two teams also want to just show us their video so that we can see their faces. So that would be nice. So Angela and Richard, so it's great. We can see the Stellenbosch team at the Winelands, and there's our Durban team. So who's going to go first? Let's give him are you guys ready? Angela, are you guys ready?
We haven't had a chance to discuss. I'm looking at everybody's and
okay.
They look similar, so maybe we can do heading by heading and we'll get a consensus for each.
Okay, great. Okay. Yes, perfect.
So for immediate cause of death, I think we've all got sepsis. Okay, probably a bloodstream infection. In the chain of events, I've got NEC. What do you have? And I added pulmonary hemorrhage and PPHN. And then other contributors, prematurity.
Oh no.
Yeah.
D, the underlying severe prematurity.
Yeah.
That's the, and then other significant contributors.
Do you have others?
I guess HIV exposure was one of them.
Yes. Good.
And
then if we go to the pathogens of interest, well, definitely Klebsiella pneumonia. The Acinetobacter may have been significant in this child. The others, potentially a lot of them look like environmental organisms, but maybe the Pseudomonas is relevant. And then in terms of modifiable factors, this very sad story that Ziyaad shared is obviously mom was diagnosed with pregnancy late, obviously not antenatally booked. Her HIV diagnosis was only made at the time of delivery. Her pregnancy-induced hypertension was identified really late, so she only got 1 dose of steroids. Is there anything else?
Can we just go back to the hospital? I just wanted to, so that white cell count on day 1 was actually quite low when you were born, even though the CRP was thingy, so we may have not picked up infection early on.
Okay. So I think we must leave some for the Durban at the Sea. Okay, so maybe think a little bit about your modifiable factors, and we're going to go over to the Durbs team to see what they think. Kind of hope you will disagree.
Okay, so we put prematurity that then led to RDS, that then led to a hospital-acquired infection, that also then led to NEC, and as of final cause of death, or the immediate cause, was septic shock. Our modifiable factor organisms were Acinetobacter baumannii as well as Klebsiella. Then the modifiable factors we had.
Okay, can I stop you guys there and maybe just ask Ziyaad to comment on, okay, maybe I'm going to share the poll for what you guys think. Sorry, let me just share this. So what do you guys think? Do you agree with how Team Stellenbosch mentioned that? Or do you think you are more on Team UKZN that mentioned the NEC and the hospital-acquired infections along the line? So you guys are very, very close. Okay, Zia, do you want to start just sharing your thoughts about how they structured that?
Are people voting?
Yes, they are.
Oh, okay, good. So I think the few things I want to make mention of is that when you put something in the pathway, remember it needs to be a diagnosis. Okay, so for example, we often put things like cardiac arrest in the pathway, or we put respiratory failure in the pathway. And I'm liking that both teams are not saying words like that. But when it comes to something like septic shock, I wouldn't put that in the pathway. Do you understand? Because shock is, the effect is shock. You have shock, but the diagnosis is septicemia, if you wanted to use septicemia. So bear that in mind when you're putting things in the pathways, that there needs to be an actual diagnosis. And often that's the problem with death certification, is people put the effect or the process rather than putting the diagnosis. So I'm looking at the poll, Marty, and it looks like it's a 50-50. Can you even get this?
It's amazing. It's like dead on the same. Everyone had the same amount of fans.
Yeah, so I think that, but I think it basically talks to the fact that they're both right. So I think the important things to highlight in this case is the underlying cause is the prematurity, and both teams identified that as the underlying cause, which means that if the baby was not born premature, these events would not have happened. And that's the learning point here. And both teams said the problem or the reason the baby was born premature is the mother. So if you go back and say what maternal factor contributed to prematurity, then you'd say it was her pregnancy-induced hypertension, the fact that she was a late booker, maybe she's HIV, that's why she also left. But whatever it is, there was factors that resulted in that premature birth. And once your baby was premature, the baby then initially seemed to be just the effects of prematurity, HMD, all those kind of things, and then succumbed to a nosocomial infection. Now, the question I was going to ask the Durban team, did it start with, would you put NEC first or would you put nosocomial infection first? So which way would you put it? So do you think, and the word you use septicemia, right? So would you put septicemia or would you put NEC in that pathway? And I'm just nitpicking here because you guys are spot on. I'm just trying to see what would you do. So what I'm trying to make you think about is that did everything start off in the gut and then you had dissemination of these organisms to the rest of the body, spreading into the blood and the brain? Or did the problem start in the blood and the brain and then go to the gut and cause a NEC? And if you're neonatologists on the panel, I'm hoping you guys are thinking about this.
Some feedback from the teams. What do you think?
We are saying that HAI led to the NEC.
Okay, so it's interesting. The point is, this is not the point to be right or wrong, but you basically think there was some process that led to hypoxia of the bowel that you think may have precipitated some sort of NEC. And then the NEC then results in the organisms of interest, A. baumannii, Klebs, whatever it is, these organisms then become invasive. They go to the blood, they go to the brain, and as you can see in this case, I'm so happy that both teams recognize that it's polymicrobial, the cause of the final cause of death. And I think the important point I want to highlight here is the ante-mortem diagnosis only showed A. baumannii, and this is often what happens. Yeah. And look at the post-mortem diagnosis. All of a sudden, let me go to the next slide. All of a sudden, you now have Klebs, A. baumannii, and you would have missed the Klebs. So we would have been saying, oh, no, it's all A. baumannii. Meantime, we missed all, and you can see this Klebs is everywhere. It's fraught with both immunohistochemistry showing Klebsiella as well in the body. So I think that's the important thing. And thank you for mentioning these modifiable factors. This could be really a preventable death. You guys can see this. Okay, so in the interest of time, Marty, can I go on for another one or?
I almost wonder, yes, so let's quickly do another one. Maybe if you can cut down a little bit on the story, that would be great.
Okay, so I'll make them read a bit more. So let me do two because the next one is quite easy, right? So the next one is a 32-year-old mother who gave birth to a stillbirth. The mother she had, when you looked at her booking bloods, her RPR theta came back at 32. Her other bloods were fine and her blood pressure was fine. But what she was referred to a clinic with no fetal movements and gave birth to a macerated stillbirth. When she came with a macerated stillbirth, that's when someone noticed that the RPR result was not written down. And that's the only time they gave the bicillin. And this is what happened when we did the sampling. When we did the sampling, this is what we got. And then we did the histology, and I'm not going to read through the whole histology, but just to nitpick on a few things. If you look at the placenta shows acute subchorionitis, chorioamnionitis, cystitis, lots of features of chorioamnionitis in the placenta. And I'm not going to read the narrative, but I just want to show you the pictures. This is what the liver looked like. This is what the lung looked like. This is what the brain looked like. And this is what the placenta looked like. And the histopathologist came back and said, you won't believe this. This is all looks like. 2 points for guessing. So I'll leave it to the teams. What do you think? Maybe
thanks.
Mati, back to you, or
Yeah, so maybe the Durban by the Sea can start this time around. So what do you think? And you guys are muted still. Okay. Angela, do you guys want to go? I can't hear any of the teams.
Oh, yep. So obviously it looks like congenital syphilis with a macerated stillbirth, everything suggestive in terms of the placental biopsies and the chorioamnionitis and the villus, etc. And obviously untreated syphilis and not checking the result is the modifiable factor. But the interesting thing is the E. coli that was found in many different organisms as well. So, you know, potentially on top of the syphilis, there may have been E. coli disseminated infection as well.
So very interesting, isn't it, Angela, that we would have attributed this death to syphilis, had we seen the RPR result, and you would have missed the E. coli that seems to be, like you said, in multiple organs. So would you put one cause of death, or would you put two causes of death? What would be your underlying cause? What would be your immediate cause?
I think I would have two causes of death. Obviously, the syphilis and E. coli sepsis.
Do you think one led to the other?
Certain. We're not sure. We'll take the Fifth Amendment on that one.
But that's another example of how it cannot be linear sometimes. Sometimes it could just be two pathologies that seem to be, and this could have been congenital E. coli infection and congenital syphilis infection, both affecting this baby.
And what does the Durban team, what do the Durban team think?
Okay.
Do
So
they
we
agree?
think the immediate cause of death is congenital syphilis.
And would you put E. coli in the pathway?
No, we would not.
Okay, so that means you only have one cause of death.
Yeah,
So I think
we only
let's get a vote on that, Marty. Marty, how's about a quick vote on that? While I give you the next case.
Okay, guys, ready to vote.
So Stellenbosch says there's two things in the pathway to death. KZN says there's only one thing in the pathway to death. Let's get some votes in.
This is an interesting one now. Okay, so we've got about 160 votes in. I am going to end that and share the results. So interesting that 79% are with Team Stellenbosch and 21% with Team UKZN. Okay, Ziyaad, which team do you go for?
So interestingly, the decode panel on our side ignored the E. coli. They said that this is all syphilis and there's nothing else to think about, because when they looked at the histopathology, what came out significant is the cause of death they thought was not the E. coli. So maybe the E. coli was identified as a pathogen of interest, but they think the cause that killed the baby, they thought. And Angela, they could be completely wrong, so don't trust them. That's just really the point. The point is, and that is why there's a panel. So one of the things that the decode panel has to also agree on, whether there's consensus in their version of what there is, whether it was a majority vote or whether there was no consensus, and that's also documented. Because sometimes they argue, and I can tell you can imagine, I chair these meetings, and I don't know when to stop making them fight about what they're deciding on. So let me give you one more. Mati, can I please have one more?
Oh, Ziyaad, yes, but you need to speed it up. Thank you.
Okay, so let me
It
jump
is
this
fun
case.
though.
Last case, right? And then we'll call it a day. Okay, teams, let's go. This is a 4-year-old child. The child was born in 2018, demise in 2022, was found dead at his place of residence. There was no visible injuries, and this is important. There was no history of a toxin ingestion. What they found was he just had a swollen foot and he had some mucus at his nose. When they weighed him, his weight was 15, which his anthropometry was normal. And the only thing they saw is they saw some swelling on his right foot, on the sole of his foot, and they saw a small wound. And it looked like it was healing. The post-mortem blood culture came back as a Staphylococcus aureus. The CSF grew a Staphylococcus aureus isolated on broth. The left lung had light growth of Staph and Haemophilus influenza with moderate growth of Viri. The right lung had heavy growth of Staph with some Haemophilus influenza. The TEC results showed a CT value for HSV of 35, Haemophilus of 32, Staph of 27, pneumococcus of 33, and then you can read the rest of them. So there's CSF had pneumococcus with Haemophilus and Pseudomonas. The lung had those organisms. The rectum had those organisms. And what the histopathologist said is that there was significant mild portal inflammation, sinusoidal inflammation with sinusoidal leukocytosis, which suggests there's some infective pathology in the liver. The lung showed a bronchopneumonia, and at that time, they couldn't see the organism on the histology. But the CNS showed a severe neutrophilic meningitis with free-lying fibropollen exudate indicative of meningitis. And then the CDC pathology showed that immunohistochemistry evidence of Staphylococcus species, and they thought it was a Staph aureus. Okay, I'm done, Mati. I'll hand over to the two panels.
Yeah. Good luck with this one, guys. This is a difficult one. Okay. Angela and Lucia, are any of you guys ready to tell us your answers? Maybe the Durban team.
Go ahead, Fred.
So our underlying, it's wound septicemia, and the final cause of death, it's meningitis, Staph aureus meningitis.
Okay. Good.
And
The
modifiable factors, the fact that parents did not present to hospital with the wound.
okay. Then from the Stellenbosch.
I think we would like to add, we agree septicemia and meningitis are the final immediate causes of death, but we'd like to add something in the causal pathway to say that he probably had a septic arthritis or even an osteomyelitis, which was the original source of the infection, or even a skin and soft tissue infection, a cellulitis, which then caused a disseminated staph infection complicated by sepsis and meningitis. Thanks, over.
And then for modifiable factors that the caregivers didn't recognize severity of illness or danger signs, and they did not take the child to the clinic. But
So why are you telling me about modifiable factors? Let me just tell you the narrative just for interest.
But you don't actually know. Yeah.
He said, the mother said he was pricked by a nail while playing outside wearing shoes. The leg became swollen and my aunt advised me to take him to the church. At the church, they poured paraffin on the leg saying it's due to poisoning. The leg became worse because it started swelling up to his thigh. He started urinating nonstop and drinking lots of water. He was always thirsty. He could not eat. His whole body was painful. I took him to the clinic, but he was not given treatment. During his last day, he was spitting out black stuff. And then he died. Sure, that's depressing. I shouldn't have ended with that.
Yeah.
That is
Okay.
very depressing, Ziyaad.
Yeah, that's definitely our system's failure.
But there was a child in South Africa, same story, just out of, now you've got me down my 18. So a 13, 14-year-old boy who died of disseminated staph, eventually got to healthcare. They x-rayed him. The x-ray looked so bad, the staff thought he had pulmonary tuberculosis. He was not treated for staph with antibiotics. He was put on TB treatment. You know, so staph, disseminated staph always catches people out. Sure.
Yeah, and we see so much at the moment, all these big, well-grown kids with disseminated sepsis.
Heartbreaking.
It's
Yeah.
very sad. But thank you so much to Team Stellenbosch and to Team Durban. You guys were wonderful. Thank you. Ziyaad, any last words or a bit of a summary from you?
Yeah, so just to thank both of the teams for participating. I mean, like I said, the exercise was really to give us the feeling of the complexities around determining what cause of death is. And I think the point I want to end with is that the more information that we have, the better our ability to determine what the cause of death is. Can you imagine, had we taken out the diagnostics for both these cases, you can imagine how we would have a very limited overall determination of that cause of death. So there's so much more information that the histology gave us, that the microbiology gave us. And again, then the plea then is to say, at our various hospitals, and I accept the resource limitation, should we be doing it even in a minimalistic way? So maybe even just start with every pneumonia getting an aspirate of the lung after they die, sending it for microbiology. May just be all that we need to do. And we have to sensitize our registrars and doctors on the ground that this is not something that we should shy away from. And a lot of the caregivers, I mean, Marty, we've seen this, a lot of the caregivers want to know. So when you approach them, yes, it is a sensitive time. You have to do it with a lot of empathy at that point in time. They need some counseling, but to say to them, by taking a sample, we'll be able to give you a better sense of what the cause of death is. Most caregivers are saying yes, because they do want to know what caused the death in the child. So I'll end with it and express this importance about looking for a more granular assessment of it. And thanking the panelists again.
Yeah, that was fun. Thank you so much. Ziyaad, at what point, because what I sometimes find with all these organisms, and I think that's what they also find today, at what point do you decide to ignore specific ones? So is it based on the discussions that you have with your team? Or clinically, and maybe Angela can also help a little bit, because I think doing these myths, you get all these stuff, but what do you actually, how do you decide I'm going to ignore these?
Oh, absolutely. I mean, Angela is the expert in this, but you have to accept that there is firstly polymicrobial infection, but we also know there's organisms that are just there, not of particular interest. And especially when we use tech, because we're using molecular diagnostics, so any genetic material we're going to pick up. The important thing, and I presented this at the Westport conference last year as well, and someone stood up and says, that organism is just from the rotting body. That's not a real organism. And it's a reality is that as the body starts rotting, there's overgrowth of organisms as well. So you have to take that with in the context, you have to see and say, what are the likelihood of that organisms being pathogenic? And I think the CT values do help. If you find organisms in multiple sites, the same organism coming up, it's also an indicator. But there's never a right and wrong. And I think that's the part of it is you need to have some sort of consensus.
Yeah, that's great. What does a MITS cost? Do you know the cost of a MITS?
Yes, so the full procedure as it is now is very expensive. It can be anything between $10,000 and $17,000. That's the current, right? But that's because before you don't stress. The cost is taking into consideration every histopathology sample because we don't puncture one site, we're puncturing multiple sites. So even in the lung, we're doing 6 in the front, 6 in the back, which means that you're doing 12 samples and you can imagine every sample you run is then a cost. But so what I'm saying is that let's just say, hypothetically speaking, a child with pneumonia came in and you knew when you auscultated, there's a consolidation in the right upper lobe. Stick the needle in the right upper lobe, or if you had an X-ray, stick the needle where the problem is, and then you're more likely to get a better idea. So what they're trying to do at the moment is they're trying to reduce the cost if they can, but you're never going to get it to a cost that's acceptable for a low resource setting or public facility.
Okay. Well, thank you so much. So it is important for us to know, and especially to tunnel some of that modifiable factors as well. I think that's important. Anything from our teams? Any comments from the teams, Angela?
I'm Marty. Thanks for this. I just want to make a comment about our child death reviews that we have in the Western Cape, which is a kind of multidisciplinary team that reviews all deaths that appear at or get admitted to forensics. So just to note that the majority of our deaths that happen in hospital are expected, and it's not that complicated, or not, it's not that complicated, but we often know the cause of death beforehand. But I think if we would have to implement something like this, it would be, it would have to happen at the district level, and we also don't have a lot of deaths in hospital within the district, but we have a lot of unexpected deaths within the community. So the difficulty would be which kids, making a decision as to who goes to forensics and who doesn't. And sometimes you think, oh, it's easy enough, take a post-mortem X-ray, but we have also found with some of these autopsies that some of the children actually have had non-accidental injury. The history doesn't always match the presentation. In fact, it never does. But also what Ziyaad said is also true, because we do see a lot of polymicrobial infections causing pneumonia. I mean, more than half of the Sudis are caused by pneumonia or septicemia. But yeah, so it's a difficult, I think there's a tension. It's difficult as to what would be the best, because you could save some money by not doing a full autopsy, but also I doubt whether.
Yeah, but I think you're right. The district, for every child that we investigate in hospital, and we put such an effort in around the discussion in mortality, there's one dying outside there that never probably gets discussed, and that we don't have a real cause of death for. So I think that is very important. Any final words from Team Durban, because we do need to end?
Thanks, Marty. I think we were just discussing in terms of, even if we're implementing the lung biopsies, it's not standard of care as much, but as Ziyaad said, it was being done before. So in terms of is just consent from the mum enough, or are there other ethical considerations we'd have to take before we implemented it? A lot of our deaths in this unit at Albert are surgical, so they usually end up going for forensic PMs, but the minority of deaths that are not surgical, what would be the ethical implications of what is there a process we would have to do first before we can implement?
Ziyaad?
Yeah, so I mean, we're exploring it in the context of research, and obviously there's a full consenting process required. But I think we need to decide within the departments what is acceptable as standard of care. And I think it comes back to that. And like you said, we did it before as standard of care. And I remember it wasn't an extensive consenting process. We would go and take the sample. But I think the right thing to do is to have a consenting. And I think it's to explain that to the parent that we are going to take the sample. We're going to puncture, and it's a needle prick. It's not going to be noticeable. We're not cutting the body. And I think that's the way I would like it to happen. And obviously that's a discussion, but you basically within the department, one decides and says, what is acceptable as a means of a diagnostic process? And I'm hoping that the department comes in and makes a recommendation that we should be looking for that in a limited capacity, and I accept the cost in that. I think that's why we have to say limited and we have to say directed. I think it has to be in a specific context and when it becomes useful, because it's not always useful to do that. Yeah. And then we say, okay, if we're going to do that, let's take the consent from the mother and let's proceed.
And then obviously to engage our pathology, histology services in the fact that we're instituting that.
Yeah, no, absolutely, because it's going to come to them and they're going to complain about the increased samples.
And I think the follow-up for our forensic postmortems are also very important, because they do culture often, and then we don't always get those results because it is a bit of a mission to follow up. So I think that's also very important, because that's not an extra cost. It just costs some follow-up. I don't know, Shagan, if you are still there, any last words from your side, and then I will close the meeting.
Thank you so much. I think it was fantastic to have a bit of interaction and see how we can practically apply these concepts. So yeah, thank you to our speakers, and obviously thank you to everyone that has joined. Yeah, we always appreciate all the attendance and people participating. Thank you so much.
Right, so with that, I want to thank our panelists. Yasira's already had to leave for another meeting. We will share these presentations on our website, and they will be on YouTube. So if you missed part of it, it will be on YouTube by tomorrow. So thank you very much. Join us again next month. We will be giving you a RSV and pertussis update. And hopefully, like, by supporting SAPA, hopefully we can grow the community of pediatricians and that we can learn together. So thank you for joining, and thanks again for our speakers. Goodbye, guys.